Our first speaker tonight is, where is he? Here he is, right here. He is the chief of the Brain Sciences Center at Sunny Brook. I can't even speak right now because I'm in the moment of greatness here. At Sunny Brook Health Sciences Center, Dr. Anthony Levitt. Please welcome him.
Good evening, and thank you very much for coming out this evening. I'm going to spend my time talking about bipolar disorder, hope for the future, or should I say, hope for the present. And the reason is that right now there are so much exciting things going on in the field, new potential treatments and ways of understanding the illness. And so that's what I'm going to focus on. I don't believe that I'm creating hope. This is a story of hope, just as Eli's place should be a place of hope for our young people with a variety of conditions. But I'm going to talk about bipolar disorder. I'm going to spend the first part just giving you some, background information, and the last part talking about some of the new work that's going on that's very exciting. So the overview, I'm going to talk about what is bipolar disorder. I'm going to talk about the principles of treating, of managing bipolar disorder, and then I'm going to talk about some of the new directions. So, what is bipolar disorder? It has a prevalence, depending on how you define it, we're going to talk about this in a second, but type 1, which is the classic kind of manic depressive illness, bipolar disorder, has a prevalence of about 1%. So 1% of the population in their lifetime will develop bipolar disorder. Bipolar type 2 is about 1.5%. And there's a third kind of bipolar disorder which is clearly causes dysfunction and difficulty but doesn't quite fit into that category. It's called bipolar NOS, not otherwise specified. And that's about 2%. So together about 4.5% of the population will have at some point in their life bipolar disorder. Compare that to asthma, which is about 5% of the population, hypertension, which is about 8%, schizophrenia, which is 2%. You begin to see this is one of the most common medical conditions around. Now, depression, which is just the one pole of bipolar disorder, which unipolar depression, which is a different condition, 1 in 4 people in the province of Ontario at some point in their life will have an episode of major depression. It's far more common. But I don't want to make it sound like bipolar disorder is not common. It is. It's roughly equally distributed across sex, as many males as females get this condition, and also relatively evenly distributed across ethnicity. It knows no socioeconomic barrier. It affects people across the socioeconomic classes. Now, this is an important notion, that the age of onset of first symptoms, the median age, is about 17. And the median age that develops into a full-blown syndrome, a full-blown episode, is 19. The age at which someone is diagnosed, however, is on average is 21, and the age at which they are first treated is 23. In other words, it's been 6 years since they first had symptoms on average before they actually get treatment. So we have a major issue, a major public health issue in our society, in that for 6 years, young people are suffering without appropriate treatment. And that's just the way it is across North America, Europe, Australia. Same story. There is this bimodal age of onset, so typically this disorder starts between the ages of 14 and 24, but there is the secondary peak that occurs between 45 and 54, and we really have not been talking about that very much. And it's nowhere near the same peak as it is in youth, but there's this secondary peak, which is kind of a fascinating peak. Is now sort of research is now focused on that. And the last thing I want to talk about with bipolar disorder is course. But before I talk about course, I want to talk about the symptoms. So I'm not going to go through the symptoms of depression. I'm happy to talk about it later if you want me to define, but bipolar disorder only occurs if someone has mania. So the only thing that's required for a diagnosis of a condition that's called bipolar, manic depression, the only thing that's required is a mania. As soon as someone's had an episode of mania, they have a diagnosis of bipolar disorder. And that's because only about 10% of people have what's called unipolar mania. They only get manias, they never get depressed. 90% of people get mania and depression, but it's the mania that defines it. And of course there is mood elevation or intense irritability. And this is often misunderstood. People don't understand that intense irritability can be the mood symptom of mania. People become indefatigable. They have boundless amounts of energy. They don't sleep and there's no need for sleep. They have inflated self-esteem, an inflated sense of their own value, grandiosity it's called. They have accelerated thoughts and accelerated speech. They're very distractible, can't keep their mind on one topic, go from one to the next. And they get involved in destructive behaviours without awareness of the destructive and dire consequences. And this is largely what gets people into trouble with bipolar disorder. They say things, they spend things, they get involved in relationships they wouldn't ordinarily get involved with, and they drive erratically, etc. So there are things that get them into trouble. Now, someone with mania doesn't necessarily have all those. You actually have to have 3 or 4, depending on other criteria. 3 or 4 of those within the same period of time, and that's mania. Mania is not that hard to miss. Depression can be easier to miss, but mania is not hard to miss. Now the course. There are several things that define the course, and I'm sorry to be so complex, but I'm going to excuse myself for a second and be complex. The first thing is the severity. If someone has a severe constellation, where they're getting into such severe trouble that their life or others' life are in danger or they need hospitalization, that's mania. But if they have the same constellation and they're marginally functional, that's called hypo, or just below mania. In Latin, hypo means below. I know people talk about hypermania, there's no such thing. Mania itself is hyper. But if you're slightly less severe, it's hypomania. And that's the difference between bipolar type 1 and type 2 that I mentioned before. Bipolar type 1 is full-blown mania. Bipolar type 2 is it's hypomania, less dysfunctional symptoms. Then there's the frequency. So people who have more than 4 episodes, whether that's mania or depression, in a 12-month period are considered to have rapid cycling. And rapid cycling is again a slightly more severe phase of the illness. But you can also have ultra-rapid cycling. And that is some people cycle during the day. They wake up in the morning and their mood's pretty good, and as the day progresses, they become, so that the high, I should say, of manic, as the day progresses, they become depressed. So it can be ultra-rapid within a day cycle. There's the predominance of features. So if someone is predominantly manic, it's a slightly different constellation than if someone's predominantly depressed. Or you can have a mixed state. So the notion that these are 2 poles is kind of brought in sharp contrast here, because some people can be both manic and depressed at the same time. And we call that a mixed state. 40% of people with bipolar disorder go through a phase of a mixed state. And so there are some people, including my dear friend and mentor, the late Russell Joffe, who says it's actually 2 illnesses. It's a depressive illness and it's a manic illness. They happen to be happening in the same person because they can happen at the same time. There's what precipitates it, whether it's a medication, a season, a substance, a stressor, including a medical condition. There are associated features like anxiety, personality disorder, family history. There's this notion of whether they get better between episodes. So some people have chronic bipolar disorder where they virtually have no period of wellness. They go straight from mania and depression, from one depression into a prolonged depression, and some who recover in between. And then the last issue is the inter-episode function. When they do recover, are they back to normal? Are they back to healthy? Are they back to well? Or do they have some residual symptoms? It's kind of like someone has acute heart failure and they recover, but they continue to have some symptoms of heart failure. In this case, someone might have an episode of mania and still continue to have symptoms. That's called inter-episode functioning. And the reason I'm telling you about all these is, if you combine severity, frequency, predominant mood, etc., those 7 items, I've counted there's over 192 ways someone could present with bipolar disorder. So, has anyone seen Silver Linings Playbook, the movie? The director's son has bipolar disorder, so he fashioned that character after his son. And I was asked by CBC Radio, is that typical of bipolar disorder? And I have to say, there's 192 ways bipolar disorder can be typical. And this makes it, and the other thing you have to realize is, it's one of the few illnesses, when you treat one phase of the illness, you can create the other. If you treat depression, you can precipitate mania. If you treat mania, you can create depression. So imagine someone with asthma, every time we try to treat their wheeze when they breathe out, we caused a wheeze when they breathe in. Right? That doesn't make sense. Treatment of asthma should do both phases of that illness. And so it becomes, in fact, the most complex of all medical conditions and the most complex to treat. So if you do surveys of physicians in the community and ask them of all the medical conditions, blood pressure, heart disease, and include bipolar in this, they will rate that bipolar is the most complicated to treat. I'm just flashing this here because it's very topical. This are the 6 studies that exist in literature about whether cannabis can affect the course of bipolar disorder, and every one of those studies shows that it increases the risk of developing bipolar disorder between 2-fold and almost 5-fold. Now, there is some question, can cannabis be used to treat bipolar disorder? And there's no scientific evidence, there's anecdotal evidence, but, antidepressants can be used to treat bipolar disorder. In some people, they help. In a lot of people, they produce mania and they make the illness worse. So there are compounds that can help some people to make a whole lot of people worse, and cannabis may be in that field. Okay, principles of management. I use the word haystack here to tweak my memory. Someone said recently that looking for a new treatment for depression, or even for bipolar disorder, is looking for a needle in the haystack. Only most of the needles have been removed. We have 28 antidepressants available on the market. We have about 10 agents, most of which are anticonvulsants, which are mood stabilizers, anti-manic agents. And so the haystack is essentially empty. What we don't need is a new needle, we need a new haystack. And so I'm going to talk about, the majority of what I'm going to talk about is the new haystack here. But there are antidepressants. The good and bad about the antidepressants are they can help people with depression. Unfortunately, they provoke mania and they provoke rapid cycling. And as you recall, I said rapid cycling is a phase of the illness which is slightly more severe. So antidepressants can actually set people back. It's not that they're absolutely forbidden, but they must be used with great care. Anti-manic agents are also very effective, but when they bring someone down from a mania, the person can crash into depression, so one has to be very careful with anti-manic agents. Mood stabilizers. So why have I written it 3 times? Because it's the, I don't know if there's people here involved in real estate. When I went to buy my first house, the real estate agent said there are 3 rules of real estate: location, location, location. There are 3 rules of managing bipolar disorder: mood stabilizers, mood stabilizers, mood stabilizers. And so what will happen is someone will be started on a mood stabilizer. It may not work. The person could still be depressed. So an antidepressant is added. But an antidepressant destabilizes the illness. The answer is a second mood stabilizer. And if that's not working, the answer is a 3rd mood stabilizer. And that is because this is an illness of the brain, as I'm going to describe in a second, that is an illness of circuit failure, of circuit dysfunction in the brain, and we can't always get it right with a single medication. There's many circuits in the brain, and we have to try and cover as many as we can. Of course, I don't want to leave out psychotherapy, and the 2 major forms of psychotherapy. There are many that have been shown to be effective. The 2 main ones are cognitive behavioral therapy and dialectical behavior therapy. This is another 2-hour presentation, and I'm told I don't have 2 hours, so I'm not going to go into these 2, but they are effective as treatments in combination with medication. In the rare circumstance, they can be helpful by themselves. But typically they are part of a combination of medications and psychotherapy. And then the last issue that I'm going to talk about is neuromodulation. This is the new treatment. So neuromodulation refers, and this is the definition by the Neuromodulation Society, the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or magnetic stimulation, to specific neurological sites in the body, modulating nerves. And the brain is the central, guess, clearinghouse of nerves in the body. And so neuromodulation for us means going after the brain with some kind of external stimulus. And there are multiple treatments. The 5 most common are electroconvulsive treatment, ECT, transcranial magnetic stimulation, TMS or RTMS, transcranial direct current stimulation, TDCS, deep brain stimulation, and ablation therapy. The example of ablation I'm going to give you is focused ultrasound. So these are new treatments for depression and for bipolar disorder. And they're going directly to the organ and directly to the site in the organ we believe is problematic. So let me talk, by the way, I'm not going to talk about electroconvulsive therapy. I will say, however, it is the most effective treatment we have for depression and the most effective treatment for mania. Unfortunately, it has significant side effects, and it requires a general anesthetic, and some of those side effects are not just acute side effects, they persist after treatment is finished. So I want to tell you though, it is still the most effective treatment, but that doesn't mean it's not problematic. Let me talk about the other treatments though. So transcranial magnetic stimulation, I don't know if you can see very clearly, it's not that large an image. There's a woman sitting in a chair having the treatment with that sweater on. She's sitting calmly, she's awake, there is no anesthetic, and a magnetic impulse is applied through a paddle, and that magnetic impulse goes a couple of centimeters deep into the brain and targets a circuit that I'm going to talk about in a second, and it turns off that circuit. By stimulating it, it turns it off. This treatment can be applied now for 3 seconds is all that's required to get the effect, but it does have to be done multiple times, so typical treatment would be 5 times a week for 4 weeks. And there's evidence it works for depression, there's growing evidence that it works for mania. The second is TDCS, transcranial direct current stimulation. A rather sad-looking figure there. But has anyone here ever had TENS, T-E-N-S? It's a treatment for, right, okay, so it's a transepidermal nerve stimulation. It's for peripheral pain. So let's say you have pain in your hand, they put an electrode here and an electrode here. It passes a small current between the two. It's called an interferential current. It interferes with nerve conduction. It turns off the pain fibers, so you actually get pain relief in your hand. Now this has been applied to the brain. The electrodes are placed on exactly where you see them there, slightly more laterally. It goes to the exact same area we're targeting with the previous treatment, with TMS, to switch off that circuit. It can be done at home, 15 to 20 minutes in the morning. Is it as effective as transcranial magnetic stimulation? Probably not. But it's very simple. There's very few side effects. It's done on an outpatient basis. Neuromodulation or deep brain stimulation. Again, I don't know if you can see that. This is now neurosurgery. We have to create burr holes in the skull, and electrode is passed through that into that exact same circuit that the previous 2 treatments are targeting. A cord goes behind the ear and a pacemaker is placed in the chest, and we can alter that pacemaker. The purpose of the pacemaker is to stimulate the brain and switch off that circuit. It kind of sounds weird. We're stimulating the brain, but we're stimulating it to switch off the circuit that's malfunctioning. Now, this takes sometimes 10 to 12 months to work. So some people notice it immediately in the operating room, but typically it's 10 to 12 months, and so other treatments have to go on in the meantime while we're waiting for it to work. It takes the brain about 10 to 12 months to figure out a new pathway to take, a healthy pathway. And then focus ultrasound. So this is a patient who's going to an MRI machine. You can see she has a frame that's been attached to her skull. She's going to sit in the MRI machine, and then on the frame is a dome which has ultrasound transducers. The ultrasound shoots beams into the brain. Now, has anyone had ultrasound for, let's say, a sports injury? Right? So it warms up. When it's on your skin or on your muscle, it warms up. And that's what ultrasound beams do. They warm up. But one ultrasound beam does nothing. It passes through the body. Mums have ultrasound for their babies all the time. It doesn't do any damage. This cap has 1,000 ultrasound transducers. They are focused on one area, and they essentially cut that area by burning it inside the brain. And this is the exact same circuit I'm talking about. All these treatments go to the same circuit. And by doing that, that's a permanent treatment that potentially has the possibility of permanent relief. And that's the surgeon in the middle. You can see the gentleman with the scrubs on, there's Dr. Dixon. He's the surgeon. He's doing surgery using a mouse because he's operating the mouse to choose the part of the brain. And when you're standing in that room, you can, I don't know if you get a sense of incredible tension. It's the most powerful thing to see a surgeon operate using a mouse. It's going to have a permanent, potentially permanent and positive effect on someone's life. And this is the circuit here. You see it's a half of the brain cut away, and that cyan or light blue circuit runs through the middle of the brain, and you see it on the right in the schematic, goes to the hippocampus, through the thalamus through very critical parts of the body. That is the circuit that controls mood and cognition, and that is the circuit we believe to be disrupted. And every treatment I've talked about, every neuromodulatory treatment, goes to that exact same circuit. So that's a picture of a brain that you might have seen. It's an MRI, a slice of the brain in this angle. But we are able to do what's called diffusion tensor imaging. This is a photograph, a scan of the brain, which is not looking at structures, but looking at circuits. I think it's a magnificent piece of art. That is someone's brain, probably similar to your brain, showing not the structures, but the circuits. And we can now visualize the circuits, we can target the circuits, and we can disrupt those circuits. So bipolar disorder is considered a circuitopathy, a disruption of the circuit. And what kind of evidence? It's episodic. It happens, and it happens often dramatically and rapidly. Substances that worsen epilepsy, that make epilepsy occur, people have seizures, also worsen bipolar disorder, and the converse is true. Treatments for epilepsy help bipolar disorder. And that includes ECT, all these kinds of neuromodulations, every anticonvulsant, work in both phases of the illness. They work in depression and they work in mania. So in summary, 90% of what we've learned about the brain we've learned in the last 10 years. And new understandings about how the brain works and how it fails have helped us to understand bipolar disorder and develop new therapeutic modalities. And despite how severe and disabling bipolar disorder can be, it is treatable, and people with this disorder can lead productive and successful lives. Is there a cure? Perhaps one day soon, and I quote Bill Gates here. He said, "We always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. Don't let yourself be lulled into inaction." So we are definitely taking action in this regard. We believe that in the next 10 years there is a strong possibility that by focusing on circuits rather than only on biochemistry, we will find new and improved ways to manage bipolar disorder. Thank you for your attention.
We need a new haystack. You can tweet that out. Thank you very much.